Good evening, students. Today we'll discuss on the topic tonsillectomy. Now, how do you define tonsillectomy? Tonsillectomy is the surgical excision of the palatine tonsils. What are the indications of tonsillectomy? The indications of tonsillectomy, as can be seen here, are divided into three: absolute indication, relative indications, and tonsillectomy as a part of another operation. So now, absolute indications. The first one is recurrent tonsillitis. So in recurrent tonsillitis, we have subdivisions as to when you will go for tonsillectomy. Number one is 7 episodes per year for 1 year, 5 episodes per year for consecutive 2 years, 3 episodes per year for consecutive 3 years, and more than equal of 2 weeks or more of lost school in a year. This 2 weeks cannot be, has to be subsequent 2 weeks. Okay, it is not like 1 week in April and another week in November. Not like that. It has to be consecutive 2 weeks or more in a year of lost school due to tonsillitis. Okay, this is the first one. Second one is peritonsillar abscess. The peritonsillar abscess or quinsy, tonsillectomy is undertaken after 4 to 6 weeks of the first attack, and this tonsillectomy is known as interval tonsillectomy. Now in some centers, they undertake tonsillectomy during the first attack only, and that is known as hot tonsillectomy. Why do they go for interval tonsillectomy in most of the cases? This is because you know that during an acute infection, if we go for any surgery, there is a high risk of bleeding. So that is why interval tonsillectomy is of choice. Number 3 is tonsillitis causing febrile seizure. A child with febrile seizure, if you find that this is a case of the child also suffers from tonsillitis, so you can go for tonsillectomy. Now, hypertrophy of the tonsils causing aerodigestive obstruction. If the patient has hypertrophy of the tonsils that causes difficulty in swallowing or airway obstruction, then you can go for tonsillectomy. Number 5 is suspicion of malignancy. Now, when can you suspect malignancy? Now, you know that in any case of tonsillitis, you'll find both the tonsils are equally enlarged. But in some cases, if you find that there is a unilateral tonsillar enlargement, then you should suspect lymphoma in children and epidermoid carcinoma in adults, and thus go for excision biopsy. Okay, so these are the absolute indications, that is, you need to go for tonsillectomy in these cases. Now, what are the relative indications? Number 1 is diphtheria carriers. Number 2, streptococcal carriers. Number 3, chronic tonsillitis causing halitosis. Halitosis is complaint of bad breath. So many patients might come to you with bad breath, and if you check and find that the case is a case of chronic tonsillitis, then you can ask him or her to opt for tonsillectomy. Now the third one is as a part of another operation. Now what does it mean? That those operations have tonsillectomy as one of those parts. So number 1 is U3P. Now what is U3P? Uvulopalatopharyngoplasty. This is a treatment or surgery of choice in obstructive sleep apnea. Obstructive sleep apnea is where it is a condition where there is apneic spells during sleep. So in U3P, tonsillectomy is one of the parts of the surgery. Number 2 is glossopharyngeal neurectomy. Okay, now you know that glossopharyngeal nerve lies in the bed of the tonsil. Now when you remove the tonsil by tonsillectomy, after that you can approach the glossopharyngeal nerve and go for glossopharyngeal neurectomy. Number 3 is removal of the styloid process. In styalgia or Eagle syndrome, we need to remove the styloid process. So this is before that we need to go for tonsillectomy. So these are the few indications of tonsillectomy. What are the contraindications for tonsillectomy? Number 1 is hemoglobin less than 10 gram %. Number 2, an acute attack of upper respiratory tract infections. As in infections, there is a high chance of bleeding. Number 3 is submucous cleft palate. Number 4, any bleeding diathesis. Number 5, an epidemic of polio. Now in an epidemic of polio, if you go for tonsillectomy, you expose the tonsillar bed in which lies the glossopharyngeal nerve, and there is a high risk of bulbar poliomyelitis. Number 6 is uncontrolled systemic disorders like diabetes mellitus and hypertension. Number 7 is during menstruation, because there is ongoing bleeding is already there, so there is excessive bleeding during tonsillectomy, and this is usually avoided. And number 8 is when the age of the child is less than 3 years. Now why is it so? Because in a child less than 3 years, you get a very limited space for undergoing tonsillectomy. Then there is a high chance of blood loss in comparison to the volume. Okay, so this is why, and moreover in the post-operative period, the child is unable to do the gargling part. So these are the few reasons why we do not go for tonsillectomy in a child less than 3 years of age. Now the surgical methods. The surgical methods of tonsillectomy are divided into hot methods and cold methods. Now hot methods are those methods in which heat is being generated. These are cautery, especially bipolar cautery. Number 2, laser. So carbon dioxide laser or KTP laser is being utilized. Number 3 is coablation. Number 4, radiofrequency. Now in the cold methods, the dissection and snare method, it is the classic method or the most common method that is being undertaken in most of the centers. Then microdebrider. Number 3, harmonic scalpel, where ultrasonic rays are being utilized. Number 4 is cryosurgery. Now cold is being applied for around 3 to 4 minutes to the tonsils, and they are allowed to thaw. The tonsils are then they slip off from the bed. So this is the mechanism of cryosurgery. And number 5 is by the utilization of cold knife. So these are the methods of tonsillectomy. Now let us move on to the dissection and snare method. Now in the dissection and snare method, for any surgery, you should know under which anesthesia you are going to do. So the most preferred one is general anesthesia, but in some centers local anesthesia is also done. So what should be the position of the patient and what is the advantage of this position? Now the typical position in tonsillectomy is known as rose position. Now what is this position? The patient lies down in a supine position with the head extended by placing the sandbag under the shoulders of the patient. The head is being fixed by placing a rubber ring below the head, so that the hyperextension is prevented and the head does not move. Okay. So what is the advantage of this position? Number 1 advantage is, as in this position the larynx lies above the oral cavity, so any bleeding during tonsillectomy will not be aspirated towards the larynx, but it will slip off towards the nasopharynx, and then you can suction it out post-operatively. Then the surgeon's hands, both the hands are free. Okay. And number 3 is the exposure is wide in this position. So now let us move to the proper procedure. So after placing the patient in this position, we have to give a pack, laryngopharyngeal pack. Now why this pack is being given? So that the bleeding that is there, it does not trickle down towards the esophagus or larynx. Now in the operative steps, this is the dissection and snare method. So now first what do? Boyles-Davis mouth gag is being inserted into the oral cavity and is being fixed by the use of 2 other instruments, that is Draffin's bipod and Maguiron's plate. The Draffin's bipod is placed within the Maguiron's plate and it is associated with the Boyles-Davis mouth gag, and it is being fixed. The position of the oral cavity is being fixed. Next, With the next, the incision is being made in the mucosa where the tonsil reflects towards the anterior pillar. So when you make this incision with a knife, okay, you have to place this incision from the upper pole towards the lower pole. Now before making the incision, you need to place the tonsil holding forceps in the tonsil proper and then pull it medially, okay, so that the upper pole is visualized properly. Then after making the incision, you dissect the tonsil from its tonsillar bed with the help of Mollison's anterior pillar dissector and retractor. After dissecting through the tonsil, we then move towards the lower pole. Now the lower pole is there, then you have to find the lower pole proper and then you have to snare it with the Eve's tonsillar snare. Now the snare works by two methods, cutting and crushing method. It cuts through the lower pole and crushes the blood vessels. After taking out the tonsil, what we do is we need to pack the tonsillar fossa with gauges. So after doing one side tonsillectomy, you put the gauges and do the other side, and after doing the second side, you take out the gauge from the other side, and when you look for any bleeding or bleeding spots. So now if you have any bleeding spots, you just either ligate it or cautery it. Okay, ligation by sutures or cautery by electrocautery. So this is the method of tonsillectomy. Now we will move on to the complications of this surgery and the post-operative care. Now moving on to the post-operative care. First, the patient should be positioned in the tonsillar position. After that, hydrogen peroxide gargle has to be initiated. The patient has to be under cold local diet, liquid diet, and the vitals should be monitored at regular intervals, so as to know whether there is any bleeding. Then analgesics and antibiotics are to be instituted. Now one thing is, why do we use hydrogen peroxide gargle? This is because because it differentiates into nascent oxygen, and nascent oxygen, as you know, is bacteriostatic. Moreover, gargling removes any blood clot or any remnant in the tonsillar fossa, thus leading to the control of bleed. Now what are the complications? The complications are broadly divided into immediate complications and delayed complications. In immediate complications, we have hemorrhage. Hemorrhage is in fact the most important and common complication. So hemorrhage is primary hemorrhage and reactionary hemorrhage. Now what is the difference between primary and reactionary? Now the primary hemorrhage is when the bleeding takes place during the surgery. It is a primary hemorrhage. Now why could it be? This could be due to injury to any of the structures, and this can be due to bleeding from any of the bleeders in the tonsillar fossa. So you can either ligate the bleeding vessel or cauterize the point, and any injury to the surrounding structures can be taken into consideration during surgery. So this is the management of primary hemorrhage. Now what is reactionary hemorrhage? Reactionary hemorrhage is that which occurs within 24 to 48 hours of the surgery. Now why does it occur? It occurs due to the slippage of ligature or presence of any clot. So what is the treatment? You just remove the clot and ask the patient to gargle properly. This is the treatment of choice. Now next is injury. Injury could be to the uvula, soft palate, tooth, tongue. Okay, any nearby structures can be injured. Now number 4 is aspiration. Aspiration of blood can be there in few cases. Okay. Then the 5th one is surgical emphysema. Now surgical emphysema occurs when there is injury to the superior constrictor muscle during the tonsillectomy, so that it Now what are the late complications? Late complications, the first one is secondary hemorrhage. Now secondary hemorrhage is that bleeding which occurs during the 5th to the 10th postoperative day. It usually occurs due to infection. So how do you treat it? First, you go for gargling, you go for packing the fossa with the adrenaline, and before that, if there are any clots, you should remove the clot. If it does not and broad spectrum antibiotics. Now if it does not suffice with all these measures, then you have to go for pillar to pillar suture. Okay, and this has to be in the OT. Now the next one is infection. Infection, broad spectrum antibiotics. Number third is tonsillar remnants. Now in many cases it has been seen that after tonsillectomy, few small bits and pieces of tonsils remain. So what happens in the long run, these bits and pieces hypertrophy, and these may act as a foreign body sensation. The patient complains of foreign body sensation, and it is due to tonsillar remnants. Then number 4 is recurrence. Similarly, if you have some remnants, there can be a recurrence. And also in many cases, lingual tonsil hypertrophy has been seen. What happens is when you remove the tonsils, the lingual tonsils which are there behind the tongue, so these have been seen to hypertrophy, and this is also a cause of foreign body sensation in the post-operative period in the long run. So this is all about tonsillectomy. So if you have any queries, do link it below and I'll be happy to answer to your queries. Thank you.